please. Yeah.
New thing on the table.
One minute morning, ladies and gentlemen. Good morning, everyone. Welcome to today's meeting of the Suffolk Health and Wellbeing Board. For anyone who doesn't know me, I'm Councillor Paul Sutton, Chairman of the Health and Wellbeing Board and Deputy Cabinet Member for Communities and Public Health. This meeting is being broadcast live and will be available to watch on the County Council's YouTube channel after the meeting. Quick reminder to members of the public and press, you're welcome to record, film, photograph or broadcast this meeting whilst the meeting is open to the public and press, provided this is done with due courtesy and respect to everyone present, in accordance with the Council's published guidance. We're not expecting a fire drill today. However, should the alarm sound, please follow the fire exit signs to leave the room, and fire evacuation instructions can also be found on page 4 of the agenda. Finally, I would ask everyone to ensure that their mobile phones and laptops are set to silent if you haven't done so already. Thank you very much. Right, we ready to go? Yeah. The first item on today's agenda is the election of a Vice Chairman of the Board. Are there any nominations for the position of Vice Chairman?
If I may, I'd like to nominate Ed Garratt.
Yeah. And thank you. Is there a seconder? Who do we take?
We'll take anybody.
Yeah, take up. Yeah, we'll take Will Pope. Yeah.
I'm very happy to second Ed. Thanks.
All right, sorry.
That was Tim.
Tim. Right. Thank you. Are there any further nominations? Is the board content to agree that Dr. Ed Garratt is elected Vice Chairman of the board for the municipal year of 2026-27? I'll take that as a yes. Thank you very much. Just wait for Ed to take his seat. Yeah. And agenda item 2 is public questions. I can confirm no public questions have been received for today's meeting. And we're on to item number 3, is apologies for absence and substitutions. Are there any apologies for absence for today's meeting, please?
Yes, we have apologies from Arthur Charvoina, John Dugmore, Rachel Kearton, Councillor June Mummery, Councillor Philip Faircloth-Mutton, Councillor Jan Candy, Councillor Laura Smyth, substituted by Councillor Sally Davies, Sarah Jane Smedmor, substituted by Danielle Lexton, Andrew Cook, Henry Griffiths, and Councillor Nic Bartholomew, substituted by Councillor Corinna Hudson.
Thank you. Agenda item 4 is declarations of interest and dispensations. Do any members... Sorry. Yeah.
Thank you, Chair. Yeah, I'd just like to declare an interest because I'm an employee of Norfolk County Council. So with respect to item 6, Norfolk County Council is a contingent partner in the Norfolk and Waveney Integrated Care System. Thanks.
Thank you. Is that noted, yeah? Right, thank you, members. Right, on to item 5 is the minutes of the previous meeting. If this was held on the 12th of March 2026, are those of you who are present at the meeting on 12th of March content to approve the minutes, please? Looks like it, yes. Thank you. I'll sign the minutes at the end of the meeting. And we'll now move on to the day's main business. Which is agenda item 6 is an update on the emerging neighbourhood plan for North Suffolk, Lowestoft and Waveney, including progress from the Great Yarmouth and Waveney Frailty Test Learn Grow project. I'll now invite Jenny Blades, Head of Operations and Partnerships North Suffolk, and Mark Burgess, Executive Director of Primary Care and Neighbourhood Health, Norfolk and Waveney, to introduce the report. Please.
Many thanks, Chairman. And may I first start by saying thank you for the opportunity to provide Board with an update on this really quite important work, I hope you'll agree, for the residents of North Suffolk. So while today's presentation focuses very much on the work and developments in North Suffolk, specifically Lowestoft and South Waveney, I'd like to reassure that it absolutely is linked in and builds on the work that's happening across the rest of Suffolk, and actually the next update that we bring, we'd like to, will be across the whole of Suffolk. But because this is a very specific piece of work, we were keen to bring it here and hopefully gain the support of the Board. This work is positioned within the NHS neighbourhood health agenda and Suffolk's ambition to improve outcomes for local residents through greater integration, which is so important. We know there's a strong evidence base that when we join up services, we deliver better outcomes for our residents, and so that is really at the heart of this. The work supports the Health and Wellbeing Board priority of supporting people to age well, and that's a key strand. And I hope from the paper that we're presented in the slides that we hope to take you through today, that will be apparent, and we look forward to questions and discussion to follow. So in terms of the purpose of today's paper, it's to update the Board on the neighbourhood plan, to share learning from the Frailty Test Learn and Grow programme, which has had some really positive early results, and set that foundation for the next stage of the programme that we would like and seek your support for. We are now moving from that planning and framework development into implementation and delivery. Partners are very supportive of this. The providers across all sectors are really keen to work this way, and actually one of the most important bits of feedback we've had is from staff as well as residents that they like working this way because they feel they're able to do a better job, and I think that's really, really important. In terms of the national context, the NHS 10-year health plan and neighbourhood health framework require a shift away from organisational silos, and this is one of the complaints that we hear very often from our residents and patients, is that siloed way of working is not what they want. They have to tell their story too many times. So with this initiative and the work across the rest of Suffolk, we're trying to make sure that we really do integrate services better for our residents. In this new approach, we're looking for services to be organised around neighbourhoods and populations rather than organisations. And the kind of local evidence, the national evidence and the international evidence suggest that we get improved outcomes and improved experience for our residents where we do that and do that well. There's absolutely a focus on prevention, early intervention, and better coordinated support, and they are really central to the model that we are developing and looking to implement here. So we are moving from a fragmented delivery arrangement to neighbourhood-based, population-focused care, and I, for one, am really quite excited about this. So what is changing? Neighbourhoods will now become the organising unit for service delivery. Again, this is what we hear from our population. They're not really bothered about how we work across services and across organisations. They just want to get the care that they need and received in a timely fashion. And I think it's our collective responsibility to try and ensure that we deliver that for them. Many of you will know about the integrated neighbourhood teams that are developing and have been in place in Suffolk for some time. But that's about bringing together health, social care, community, and very importantly, voluntary sector partners around that shared population. And I think, let's not overcomplicate this. This is about building trust, improving communication. And as one GP said to me quite recently, they felt they'd cracked it when their social worker had their coffee mug in their coffee cupboard within the practice. So this is about relationships, communication. How can we join things up better, which is so important. In terms of the ambition, it's about preventing avoidable deterioration. It's about reducing unnecessary hospital admissions and long-term care need as a result of that. It's about supporting recovery, independence close to home, and about reducing delays and the need for more intensive services in the longer term. How are we going to go about this? There's some really quite exciting developments around population health management data. We are blessed with great data now across our services to really try and identify those cohorts, those individuals who we could do better for. So at the real heart of this is using that population health management data to identify cohorts that we can work better to support. And that's really driving a lot of this agenda. But that's not to say that's at the cost of local intelligence, professional insight, and the resident and community voice. It's how do we bring these together to make sure that we do better for these individuals. In terms of the governance, we have the Great Yarmouth and Waveney Place Board structure in place, and that has the governance to make sure that the work of both the pilot to date and the work in the future to make sure we're delivering what we need to. So this model is designed around people and communities, creating shared accountability across organisations. And as I said earlier, that is one of the things that people are quite excited about, both clinical staff and non-clinical staff. Working across teams in a better integrated, more joined up way is quite a fulfilling way of working because they feel they are doing better for the residents they're looking to support. So with that focus on prevention, strong evidence bases, as I say, not only does it improve outcomes and experience for our residents, but I think really crucially, it's a more financially efficient way of working too. So there are many benefits from this work. I'm now going to hand over to Jenny, who's just going to talk a little bit more about the work in Great Yarmouth and Waveney itself and plans for the future.
Thank you, Mark, and good morning. So as Mark has said, we began with a test, learn, grow approach using a small frailty pilot to test whether proactive neighbourhood care could identify and support people before they reached the crisis point. We don't have a Back to the Future DeLorean parked outside, so we can't go back and prevent today's crisis before it happens. But early intervention is probably the closest thing that we have to a time machine. If we can identify people earlier, reduce risk, and intervene sooner, we have a much greater opportunity to help people remain independent and avoid that escalation. So, as Mark said, using the population health management data and reversible risk indicator to identify people whose independence appeared to be deteriorating and who may be at risk of needing more intensive support in the future, benefiting from early intervention. Importantly, the data was only the starting point. Adult social care, GPs, community health, mental health partners then added their professional judgment through MDT discussions to determine who would benefit most from the proactive support. So, for example, Nora, and this story is a real story, so Nora's case brought the programme to life. The data identified her as someone with increased risk, but the data only told part of the story. Through the MDT process, we uncovered the impact of her dementia, the family pressures, mental health needs, and the wider risks that weren't visible through just one single organisational record. The conversation shifted from identifying risk to understanding what was driving the risk and what mattered most to Nora, which was remaining at home independently and living well for longer. So Nora's case demonstrated why integrated working matters. No single organisation had the complete picture, but together we were able to identify unmet need, coordinate support, and bring the right professionals around the individual. Her situation showed that population health data helps us find people, but the multidisciplinary approach working helps us understand them. 3 key lessons emerged. First, proactive engagement is achievable. Second, person-centred conversations reveal a much richer picture of people's lives. And thirdly, multidisciplinary working adds significant value, particularly for people whose needs cross those organisational boundaries. The pilot has also helped us understand the importance of a tiered approach. Many lower risk individuals can be supported through primary care, community assets and the voluntary sector provisions. However, those with more complexity benefit considerably from a much more coordinated multidisciplinary support. And this gives us a practical model that we can then work at scale. So we're not suggesting that every challenge has been resolved. The pilot identified further work needed around referral pathways, digital interoperability, workforce alignment and understanding our service gaps. However, it has provided strong proof of concept and practical learning that can now be embedded with integrated neighbourhood teams. So in North Suffolk, really excited that we're now moving from framework development into implementation. Over the coming months, we'll continue to refine neighbourhood partnerships, complete design work with partners and establish the operating arrangements required to support delivery. Our ambition is that by October this year, neighbourhood partnerships and integrated neighbourhood teams will be operating as a coordinated system across North Suffolk. Ultimately, this is not about structures. It's about helping people remain independent for longer, preventing avoidable deterioration, reducing inequalities, and ensuring services work together around the person, rather than expecting the person to navigate multiple services themselves. And with that, I'm going to hand back to Mark. Thank you.
Thank you. So in conclusion, I hope you'll see that we're not talking about a fundamentally new service. This is a new way of working together proactively around the needs of our local people and communities. And I, for one, and Jenny and the team are really quite excited about the opportunity that this presents for us to do better. I think this is a really positive piece of work that we're doing, and we're really quite ambitious about what we'd like to do and go on from here. So, if I may, we're seeking support from the board to endorse the neighbourhood plan, to support the strategic direction and approve the deliverables, profiles, timelines, mapping and coordination as proposed in the paper and in the presentation today. So thank you all very much for your time.
Great, thank you both. I'll now open the floor of the board. Tim? Tim, can you put your microphone on, please?
There we go, is that better? Apologies for that, Paul, sorry. Yeah, I'm very supportive of it, certainly got my support for this. In one of this area where there are a lot of huge challenges, we absolutely know that in that corner of Suffolk, very important we address it. But how are you going to, how can I put it? There must be particular challenges that are more significant than others. It's very difficult to boil the ocean all at once. So I'd be interested to see, is there going to be a degree of prioritisation? Then there's a matter of resourcing in order to tackle some of these deep-rooted problems. I'm sorry, there's quite a lot of points here. The other thing is, I'm a great believer that prevention, as you rightly say, is important. Are we really going to focus on our younger generations with lifestyles, exercise, all the other things that we're all very concerned about? And then lastly, if I may, sorry to go on a bit, I would welcome, as a suggestion, update in 6-9 months' time with some data results, evidence of how you're progressing, because that will really help get public support for it. So if you're able to reference some of those, I'd be very grateful. Thank you.
Thank you, Councillor. So firstly, as you say, this is an enormous subject, particularly when you're talking about integration of services. This affects so many areas: housing, policing, local authorities, cover such a big area. With this pilot in particular, our way in, if you like, has to be focused on frailty, and those cohorts identify using population health management data, which tends to be those where we identify there is an opportunity to do something different and improve the outcomes. Our aim is to then build and expand upon that model. Your second point around young people, absolutely, we're working with children's services as well. This is, if I use the example of in Norfolk, there are school zones and integrated teams that have a slightly different boundaries, but that we don't see as an issue. This is about how we join services up. So it's not just for older people, it's all age. But we don't want to try and boil the ocean. We want to build that evidence base to support the model and expand and grow, and making sure that we're not doing anything that counters anything we want to do longer term. And in terms of that challenge around the 6 to 9 months, we'd be delighted and actually very keen to come back and share the next bits of information, data and outcomes with the board. That would be fantastic. Thank you.
That's great. Thank you. Call on Ed now to speak, please.
Thank you. I mean, you'd expect me to be supportive of this, so something had gone wrong if I wasn't. But I wouldn't treat this as a pilot. This is what we need to do. Other parts of East Suffolk, Woodbridge is often held up as a great neighbourhood team. So full support to scale it up, within reason as quickly as you can do, because we know this works and there'll be better outcomes for the community, and the staff prefer working in teams. So it's a win-win, isn't it? So, all power to your elbow.
And with that, thank you, Ed. I was just going to say, my previous role was actually the Integrated Neighbourhood Team Manager for Woodbridge. So taking all of that learning to the north is very much part of my ambition. But what I did want to add was that we recognise co-production is really important here, and we've just secured some funding with our community health provider to ensure that that people's voice is heard as part of this work going forward.
Thank you. Stuart, have you got?
Thank you for this. I think I just wanted to set context for the board that, as you identified, this is part of the Norfolk Wellbeing change, but actually we'll be bringing more stuff back to this board about the Suffolk approach to neighbourhood health. And I think it's fair to say that we have a really good long history with regards to probably the last, is it 10 years now that we've started that journey? So for me, I think one of the things we've been talking about, what's going to be for the next 10 years, and clearly there's a lot of national policy coming from every angle at the moment about this, but what's right for the people of Suffolk? And ultimately, as Ed said, that this isn't a trial, this is about how we start to build that culture and ways of working. And the question I wanted to ask was about the focus on frailty, and completely understand why. But when we talk about frailty, we often all move to very frail older people. And it'd be useful just to reflect on, when you say frailty, we know that we've got people at all ages. If I look at Gareth working with adults with serious mental illness, just to think about what do we mean by frailty, and actually are we talking about those most frailest across the age group rather than potentially those that are more frail older? If you could just comment on that, that would be helpful.
Absolutely. So the paper references the Eclipse tool, and there's some fantastic work happening in Suffolk around the top 1%, so those who are very high users of acute services and primary care services in the round. But the data is also suggesting, as well as that group, the kind of 2 to 5% of the population, that's where there is also real opportunity to step in earlier, and as Jenny described, be more proactive, wrap the services around, making sure they're getting the care that they need. So, and some of the data that we've had come through, when we talk about frailty, people often tend to think about people 65, 70, 80 plus, but actually a lot of the data is suggesting we have people my age, slightly younger than that, I'm pleased to report, but who are also frail and show many of the markers. So, yeah, it's our way in, but yeah, that we are not being exclusive here.
Great, thank you. Joanna, who is it?
Hi, so Joanna from the Suffolk Care Association. So, thank you. I think it looks really positive and really exciting. I think in social care we've probably been crying out for this for a long time. And probably been championing it for far longer than health, if I'm honest. That is my one concern about this, is how do you get health, who historically don't see social care as an equal partner, to see them as an equal partner in your project? Thank you.
Thank you for the question. Just to say, if I may, I absolutely believe that social care are an equal partner as a health, working in the health sector. In fact, my background, I joined the NHS on a joint initiative around integrated care that was between health and social care equally. So, and I think the behaviours that we see from the teams, it feels very equal. That's my experience. Jenny, I hope I won't counter that. But for us to succeed, you know, there are benefits for our residents, there are benefits for our teams across health and social care. As well as the voluntary sector and others as well. But just to hopefully reassure, and that perhaps be something good to test us on in future sessions. But my commitment is absolutely there, equal partnership.
Thank you. And any support you want from the Suffolk Care Association, we'd be happy to give.
Great, thank you. Warren, you.
Wrong side, sorry, I need to be taught what to do. Apologies, thanks, Chair. Thank you for the overview. I think it's really helpful to see how that neighbourhood health model is emerging now and turning into reality, and I think it's quite exciting. I'm really interested in the role of the VC SFE sector, as I would be, and I'm just interested to tease out a little bit more about how that works, both in terms of the early phases of collaboration and maybe their involvement in the test and learn.
So, we already have really good relationships in the north of Suffolk with our voluntary community, and we only see that growing. So absolutely, as part of our partners and conversations that we're having, we absolutely recognise, you know, even at this early stage, that they need to be around the table, and we can only move forward with them as part of that. So absolutely, I don't think there's any part that they wouldn't be included in. We very much need them to be at the table for this.
Thank you.
That's good, thank you. And Valerie? Yeah.
Hello. So you've alluded to it a little bit, Jenny, around learnings from other neighbourhoods, and I'd just like to know what you've learned from other ones that you'll be embedding within there. You don't know, there's probably too much to tell me now, but and I guess my second bit is how will you measure impact rather than just numbers? And my third bit is how do we make sure that those who are not kind of on the population health management tool because they're not accessing services, etc., how do we actually make sure we're reaching those individuals who actually really need it, who are dropping out of the services? Those are kind of three things, but you probably can't deal with them in depth now.
Thank you. I can deal with the first bit. So with regards to taking on some learning, some of it's really quite simple, and when you've got different professionals working together, you reduce that duplication, because you may have a community nurse visiting someone, but also a social worker working with someone at the same time. By joining up and having those conversations, you're allowing that person to not have to keep telling their story, but also understand the wider picture of what's going on for that person. So in the rest of Suffolk, we have co-located integrated neighbourhood teams in place, and although that's not our journey at the moment in the north of Suffolk, there's all of that learning. When you're working next to someone and you're hearing that they're working with an individual, you can then interrupt. It's all that soft intelligence and conversations that are happening that absolutely are as important as all of the other work. So I definitely want to be introducing how can we replicate that and ensure that we're only taking all of the things that have worked really well from the rest of Suffolk and replicating that and introducing that into the north.
And if I may, in terms of the question about how do we identify the people, when I talked a bit about that, yes, we've got the population health management tool, that's one source. We also have professional judgment links in with other teams. For example, many of our voluntary sector partners, they also flag, let's take an example, homeless people who may not be engaging with services and things. So there's no wrong route in here actually, but again, we're testing this now, and I think that has been quite successful.
Thank you. Now, Will, you...
Thank you very much. And very supportive of the paper, as you can imagine, and the direction of travel, so thank you very much. And actually, Valerie you asked part of my question about impact, so I won't go there. But there's been a lot of positive comments and sentiments, hasn't there, so far. I'm just thinking about building on Tim's suggestion. Tim, I think you suggested maybe bringing back a further report in 6 to 9 months. I wonder, Paul, whether it might be worth considering, obviously you're the chair of this committee, of course, but whether it might be worth putting it on future Health and Wellbeing Board agendas as standing items so that we can get a regular update, because neighbourhoods are so critical to how we are going to work going forward. That this is a partnership critical issue, isn't it? And perhaps a quarterly update which then enables us to assess progress, monitor impact, and so on might be helpful. So that's my suggestion.
Yeah, that's great, thank you. Can I ask Stuart to just come in on that one? Thank you.
So I think this year we're going to naturally focus on neighbourhoods because the Health and Wellbeing Board has a statutory role to sign off on and have work with bring together both the health and care local authorities and wider partners to do that. So I think we can go away and have a look at it, but I think you're going to find most agendas are actually going to, we might even need to have a workshop in the autumn or something to bring some of this together. So Gareth and I were having a conversation yesterday that this is going to be a main part of what we do over the next year, because the Department of Health and Social Care have set a very clear direction about the importance of Health and Wellbeing Board to bring wider partners together along with that. So we're quite happy to take that away.
If I may say, Chair, that I think that workshop idea is a great idea. Totally supportive. Thank you.
That's great. Thank you. Thank you, Stuart. That's Tim.
Thank you, Chair, and thank you, Mark, for the paper. I've got 2 points, really. One is to do with mugs in cupboards, because I did like that anecdote. And I can reflect on it from recent experience, because up until relatively recently with the introduction of the new Norfolk and Suffolk ICB, I had a nurse's mug in my local authority cupboard. Well, I had 4, in fact. But I don't anymore, and that's because of that transformation. So I'd really love to see some more nurses' mugs back in my local authority cupboard to work with my team in a really integrated way. We're doing it unofficially, but it'd be great if that could be made a formal arrangement so that people don't feel that they're stepping outside of the structure of the NHS to work more collaboratively with local authority partners. So I hope that might come out of this. And my second point was to do with IT, because I know Jenny mentioned it, she touched on it twice actually, and I think she deliberately slipped away from it very, very quickly, because she and I will know, and many others that have worked in either the local authority or NHS will know that those 2 IT systems don't talk to one another. And before I had this role and before I had my current job, I worked in a team as a social work manager with nurses. We worked in the same team. There were all the nurses down one side, facing the wall, and all the nurses down the other side, facing the wall, and facing their own computers. And each had information about the same people, but from a different perspective. And I thought at one point, in fact, there was somebody over here, I don't think it was Gareth, I think it might have been a predecessor. There was one point over COVID where we thought we were really, really close due to having to be forced to do this, to join those systems together, so that everybody could see the same information. Now, it's great that people sit in the same room and can talk to one another. So it's great that you've got a social worker, an OT, all the clinicians sitting or based in or nearby the GP practice, and everything can hub around there. But if they're still using separate systems, the means of effectively and safely, I have to say, communicating information that may not be passed over by word of mouth, may not be passed over in a huddle, and can be recorded for accountability is a little bit flawed still. And I did wonder whether or not the reason you touched on it briefly, Jenny, was because we only have very little time here, or because there still really isn't a resolution to that bit. Thanks.
I can start, yes. We are much further forward than we've ever been. We've got health information exchange available across both lots of portals. So our site, we're much more aware of what's going on, but there's definitely still some work to be done.
And one of my frustrations over the last 15 years has always been if people don't want to engage, which fortunately doesn't happen often, it's the IT, the data sharing is almost number one every time as to, oh, we can't because we can't share data. Now, we all know that as long as it's done safely and appropriately, it's really important that we do share data. So as Jenny said, I think we're in a much better position than we've ever been on this journey, but there is still quite a bit to do.
Thank you very much. Gareth, would you?
Thank you, Chair. Just say thank you, Mark and Jenny. Really interesting presentation. In terms of the Asking the Health and Wellbeing Board, fully supportive from an adult social care perspective. I suppose concern is too great of a word, but my only worry about this is obviously we have existing neighbourhood teams across Suffolk, and what I wouldn't want to see is a fundamentally different model for the 2 neighbourhood teams in the north versus the other 14 across Suffolk. So I think there was further conversations through the Health and Wellbeing Board, and my ask of the ICB is to develop a more consistent approach across Suffolk. What we don't want is 2 health and integrated neighbourhood team plans to be signed off by the Health and Wellbeing Board that kind of get there. So just that plea for consistency as we continue to develop. Thank you.
Thank you, Gareth. And if I just may reassure, we are looking for one model, not lots of different models. And I should have perhaps stressed that earlier, and apologies if I didn't. But absolutely working with, and what's been so helpful is having the experience and what's already been developed in the rest of Suffolk, and that's kind of kicked us on further quicker.
No, thank you. Wendy, would you?
Yeah, thank you. This is thank you. This is such a lovely thing to hear about, because I know certainly from the research we do with Health Watch and our other research is so often the story that people say they're bounced around the system, especially when they're vulnerable. It just wears them out. They fall through the cracks. So brilliant to hear this. I guess my question might be, I just wondered how far this work will be evaluated from the point of the people who are actually receiving these services. Because I think those stories, like you say, we're testing and learning, and it will be lovely to know what the magic is. And I suppose my question, which sounds a bit loaded, is how that can be done independently, because it's very hard to talk to people who are providing your services, isn't it? So when we really want to know perhaps what did work, but actually what we missed the mark on, what we could have got in earlier on. So I'd just be interested in that.
So as part of the evaluation, and sorry, this relates to an earlier question I perhaps didn't answer as well as I should as well, I don't think but yes, there of course is the quantitative data around reduction in demand, admissions, attendances, and all of those elements. But just as important, if not more perhaps, is the qualitative evaluation that we will be doing and are doing in this first phase, which is for patient and resident experience, but also staff experience as well. I think it's really important we capture that and feed that back. And working with partners such as Health Watch is central to that. So that's what we're keen to do. Thanks.
And Hannah?
Yes, thank you. It'll be no surprise that I'm going to circle back to the voluntary sector in my role. So I guess my thoughts are around some of that sort of funding piece for some of this prevention work. And I know that there's a new strategic commissioning framework with the ICB and that there's sort of consideration given to that. But having been at, as I'm sure many people were, the ICB Expo on Friday, and hearing Dr. Swords, I believe it was, talking about some of these things and these real community interventions, particularly around frailty, things like slipper swaps, think Specsavers vouchers, other opticians are available, were mentioned. These are things that don't cost huge amounts, and I suppose my plea is, or my question is, when that kind of resource alignment happens as part of this, what mechanisms can there be to make sure that some of those really smaller amounts of funding that make such a huge difference can be pushed out to those voluntary sector organisations, to those communities as quickly as possible, without the tape, without the, we're talking 30, 50 pounds, we're not talking big commissioning frameworks.
Thank you for the question, and I think that's really, really important. If I perhaps use an example, we are looking to empower our neighbourhood teams and our places to do what's best for their communities. And actually, if I look at some of the recent examples where funding has been made available to support and better support communities, a very large proportion of that, working across statutory services, they have identified that the best benefit for our residents will be to spend that funding on services that you've just described. So actually, when we're empowering the teams, that is what they themselves are identifying will have often have the greatest impact. So that's very much the approach that I think has been adopted across Suffolk in the wider sense, but also in this particular piece of work in North Suffolk as well. But that's another one that we'd be keen to update on in future reports.
Lovely. Thank you, members. Is there anything further to add? We'll move on to the recommendations. These recommendations for the agreement by the board are shown on pages 19 and 20, paragraph 3 of your agenda pack. I won't read them all out, it's quite long. You've all seen them. Is the board content to agree to recommendations by general affirmation? Yeah, that looks like a yes. Thank you, everyone. Right, and we'll move on to agenda item 7, is the Move More to Feel Better strategy, a collective physical active strategy for Suffolk. And I'll now invite Gareth Davies, Director from Active Suffolk, and Mark Shorter, Head of Neighbourhood Development, to introduce the report, please.
Thank you, Chair, everybody. Thank you very much for the opportunity to address the Wellbeing Board today with this important sort of strategy. Interesting that it follows on from our colleagues of what Mark and Jenny have said regarding prevention, because physical activity very much leans into that agenda. So Move More to Feel Better is a system-wide strategy delivered by Active Suffolk on behalf of Suffolk's physical activity ecosystem. It brings together the physical activity aspirations of all our districts and boroughs into a single cohesive document. The content reflects the importance of physical activity to our county in sustaining and maintaining positive health and well-being, both mental and physical. Chief Medical Officer's guidelines suggest that adults should be doing 150 minutes of physical activity a week and children up to 300 minutes per week. But 25% of adults in Suffolk do less than 30 minutes of physical activity a week. In more deprived areas, that figure rises to over 33%. Likewise, nearly 33% of children also undertake less than 60 minutes of physical activity a week in Suffolk. Whilst the statistics are improving slowly, it's really important that we continue to work together, collectively and collaboratively, to continue to shift the dial on physical activity to support and improve the physical health of the county. Current approaches tend to provide more physical activity opportunities for people who are already physically active. Those of us in here who are physically active will often find something else to do because we're interested, we're excited about it. Those of us who most need to do physical activity are often those who are least able to reach it. And this strategy leans into that. So, why do we need to work together? behaviour change is complex. It's very simple. Me having a conversation with you to increase your physical activity is very likely to fall on deaf ears. And as such, we need to work together to create both internal and external motivation for people to change their behaviours. Likewise, we also need to work together to ensure that the right people are hearing the messages and the environments that we create for them to be physically active actually support that narrative. Clinical specialists and medical services must be supported by physical activity deliverers. This work must in turn be supported by governments and local government and councillors, listening to the community needs and sustaining and developing areas that allow physical activity to take place within the place and communities that need it most. It's often things that people don't consider that are the key changes to people undertaking physical activity. Conversations that we have had in the past about why people don't undertake physical activity were based on street lights as a prime example. The community we spoke to said the street lights don't work very well and the pavements aren't very even. So when it goes dark, we don't go out in the evening. So rather than providing something that specifically gave a physical activity intervention, working with local government to flatten the pavements and keep the street lights on actually moved the dial. So it's really important to recognise where these levers are, and it's not necessarily the obvious ones. Therefore, it's clear that to improve outcomes and impact, it is important that we continue to work collaboratively to improve our cross-sector collaboration, and we'll hear presently from the West Suffolk Alliance on the success of doing this work. The slide illustrates what we're already doing in the system to improve physical activity opportunities, and this work continues to grow, but this is a call for us collectively to improve all of these areas to offer our communities the best chance of increasing their physical activity levels at scale. Active Suffolk is being supported to do this by Sport England and has recently secured a sort of time-limited place-based investment exceeding £2 million for specific communities in Suffolk to try to move and create positive experiences and outcomes for their communities. Rather than parachute into these communities and tell them what they need to do, what we're doing is we're taking a ground-up approach. We're engaging with those communities over an elongated period to understand what their needs are, to understand what their the culture in the community needs, understand what the varying demographics in the communities need, and allow them to shape interventions that suit their needs to shift the dial. Multiple stakeholders have been brought into that. And again, as an example of that, one of the communities that we're working in is Lakenheath. Clearly, we may be aware of Lakenheath as a community. One of the issues there is cycling and walking to the school. The school is at one end of the village, a lot of the people live at the other end of the village, and the infrastructure there is not really supportive of cycling, as it's a single main road, and traffic speed and traffic levels are a significant concern to the community. As part of this development work, we've brought in Suffolk County Council's active travel team. So whilst our place-based funding won't necessarily create an intervention for active travel, the fact that we've brought that active travel team now in will potentially shift the dial for that community. So that's just another example of that sort of cross-sector collaboration, working together to improve opportunities. This presentation is timely as well, because it's likely that the Chief Medical Officer's guidelines are being reviewed and refreshed, and it is likely that they will be released tomorrow. It is likely that the focus will be on simply moving more, and those that will receive the most benefit are those that undertake the least physical activity, with the focus being on simply move a little bit more for benefit, move a lot more for more benefit. And effectively, all of us can benefit from increasing our physical activity levels. In this context, the biggest benefits are to be had by those who move from being inactive, from less than 30 minutes, to more active, between 30 minutes and 150. The more physical activity we undertake, the better. To do this, it's essential that our communities are supported to become active. And the working group agreed that the three themes of the strategy are pivotal to supporting improved health within Suffolk. In order to create active people, there needs to be active places. Those are both traditional and the non-traditional places that create conditions for people to be active under their terms and in a way that suits them, rather than being directed by everybody else. This includes infrastructure that's conducive to active travel and co-located physical activity services and clinical act services that are clearly signposted and accessible green and blue spaces. To ensure that all opportunities can be considered, the active partnerships element is how we collaborate to do this. If I may, I'll now hand over to my colleague from the West Suffolk Alliance, Mark Shorter, who will talk about how we are doing this in real time in West Suffolk.
Good morning, everyone, and thank you for this opportunity. So you'll see there on the slide the Suffolk services at the core and a number of boxes around the edge. All of these core elements make up neighbourhood working as per the framework and guidance set out by our national colleagues. And physical activity is definitely part of that, as Gareth's already alluded to. The term intersection commissioning is where multiple partners will commission elements of each of those headline sectors. The joint funding element is where we can pull funding and commission under one umbrella. There may be commissioners that have lead responsibilities or statutory duties as part of their establishment, and they can lead in that space. However, there are other organisations and teams that will have skin in that game. We can provide the system accountability and assurance through our commissioning oversight groups and our local oversight groups in West Suffolk. So as an example of this, we have a physical activity strategic leadership group in West Suffolk that I chair as an independent chair. And this has devolved responsibility from the West Suffolk Alliance. We are essentially the base for all physical activity commissioning, and we make the decisions on finance and what goes on in our West Suffolk space. There was a really successful and internationally acclaimed pathway called Exercise on Referral that was under threat and removed funding from our trust colleagues. What we did was essentially bring that strategic neighbourhood commissioning model to life and focused on physical activity. All of the system partners that commissioned physical activity in that area, of which one of our partners had 20 different contracts between about 4 different commissioners to do various things all at once, was creating a significant problem for that provider because of training of staff, continuity of funding, and the ability to flex to the services that the various commissioners were requiring. So as commissioners, we sat down, looked at the priorities of each of our organisations and identified what the key objective was that we all really wanted to achieve. The pathway that was under threat was key to that success, but we needed to tweak it to make it work for us. So we pulled together the funding. It was governed by one single ICB contract with all of the named providers listed. And that provider now has one pot that is paid to them. They have one report that satisfies an entire system. But most importantly, they have one pathway that a number of different people in our community can access. We have focused on the health perspective for people with long-term conditions and people at risk of going in for surgery and not being fit and well enough to have that surgery. We have focused on people that are currently in the housing system, particularly temporary housing, because we know at some point in the future it is likely with the postcode lottery to become one of our health inequality population cohorts. And we have also supported with funding from public health colleagues to very much focus on the prevention activity for those in our neighbourhoods already affected by health inequalities to be able to access this pathway. So by coming together as system partners and commissioning together jointly with our lead commissioning responsibilities in boot, we have essentially delivered what Gareth is talking about in the Move More to Feel Better strategy by delivering the active partnership, focusing on those active places and delivering a bespoke individual programme for people in our community to access physical activity in the right place. Thank you, Gareth.
Multiple, sorry, because I always want more. We'd like you to endorse the Move More to Feel Better strategy, recognise that physical activity is a key enabler to health and well-being, prevention and reducing inequalities, support this whole system approach, champion the strategy and cascade it within your organisations and areas of influence, promote joined-up working across health, local government, transport, education, community and voluntary sectors, review your organisational priorities and plans to understand how you might integrate physical activity into existing work to supporting positive outcomes for the communities that you support, and work collaboratively towards commissioning that aligns with the principles of the Move More to Feel Better strategy. As I look across the chamber, everybody I look at has sort of probably will see direct benefits in their area of responsibility from increasing physical activity, whether it be reduced crime prevention, positive experiences for young people, frailty prevention in older adults. So it's a significant game changer. And it's really important that we recognise this and continue to work together. In the report, it talks about the potential cost-saving measures of physical activity, and I was struck by a conversation I had the other day. And if I was having a conversation with Dr. Garratt as a prime example, as the Chief Executive of the ICB, it would be trite of me to tell him that physical activity would save him money, because it wouldn't. If you're the head of an ICB, that money will be spent elsewhere on a differing priority. But improving physical activity outcomes and integrating them into the wider health pathway might allow clinical practitioners to spend more time with people who really need the clinical who need that clinical intervention, rather than those people who are what we call that top 1%, who are consistently back with their sort of long-term health conditions, largely caused or that could have been prevented by increased physical activity levels. Thank you.
Thank you, Gareth and Mark, for that. I'll now open up the floor to the board for any questions. Tim.
Thank you very much, Paul, and thanks very much, both of you, for that. Really interesting. Really pleased, Gareth, to hear you mention about young people and crime. I'm trying to remember, I went to a meeting in London a couple of months ago, and there was an evaluation done. I think this was something to do with the youth fund, some major thing. And it was quite clear with all the grants and help that we give to various youth organisations across the county, the one that has the biggest benefit for getting people getting into violent crime, and I'm not trying to be a doomsayer here, healthy relationships, all these things, the one that came out right on top was sport by a long way. They've done a big evaluation. I can try and remember, I can't remember what the name of this piece of research that was done. But my question here really is, I absolutely agree with you. It's really, really important. Also pleased to hear you talk about the economic benefits, which very often with these things gets overlooked, and it shouldn't be. I'm just wondering what else we need to do to try and get into younger people, and I know there's also parents' involvement, that for the rest of your life being physically active, it doesn't have to be all about sport, team games, of course. There are other things. What sorts of things we could do to help, apart from saying, yes, it's a good idea? Are there specific things that we could try and do to help move it forward? Because it's got huge long-term benefits, and we should all be looking at long-term benefits rather than just next year or the year after. Thanks.
Thanks, Tim. That's a really good question. And it's very difficult to answer a question about specifics, because the reality is those specifics should be governed by the communities that you want to support. I think the worst thing that's happened in this country is that organisations with the best intentions go into an area and say, this is what we're going to do and it's going to make a difference. Actually, what they don't do is they don't speak to those communities to say what will make a difference. So we have a number of communities across the county that might need support. And an intervention in one area might be fundamentally different from an intervention in another area. So what I would say is, as we all sit around the table, is understand those communities that you wish to support, understand what their needs are, and shape interventions that they want, rather than interventions that we feel might help.
And if I might just add as well, we've actually done a specific project in West Suffolk called Bitewise. It's one of our healthy behaviour roles. So we've had a joint role with Eastern Education Group, West Suffolk College. They've been very focused on how they can support families around education, employment and training, but working together with us from a health focus. So the advisor has been going into primary schools mainly, focusing on the health inequality areas where we know it's needed most. And they've been doing a Bitewise programme, which is not only around healthy eating, it's also around physical activity. The interesting part is, though, that it's not just done with the school children. The parents are brought into that class at the same time. So it's intergenerational learning, and the parents are learning how to cook cheap, healthy, good food and get more physically active alongside their children. And that project is now being part of the Lake and Heath bid, so that we can then expand it across the rest of that area and focus as well. So there's some really interesting pieces of work that can be done, but Gareth's bang on right in terms of what is delivered in different areas may well be different suited on that local community.
Thank you. Come to Ed now, please.
Yeah, just wanted to build on the theme of consistency from the previous item. So, Mark, you've done amazing work in West Suffolk. Sounds like you've tidied up a lot of loose ends and got a clear, unified approach. I know this isn't within your remit because you work for West Suffolk Alliance, but it would be obvious to do the same in East Suffolk and North Suffolk. Are we learning across the county?
Yes, indeed, Ed. Myself and Shona Evans, who's my equivalent here in Ipswich and East, and Emma Bray have been having conversations already. We are very much into a good proportion of writing our neighbourhood plan for the whole of Suffolk. And we have included the slide that you've seen today, as well as a lot more context around how we need to commission together as a system and what brings us together, so that we will be spreading that across West Suffolk. And particularly on this physical activity conversation, I've been speaking to Nicola Jenner as well around how we replicate what we've been doing in West Suffolk over in Ipswich and East. And we've also had some conversations around some oversight across the whole county as well.
That's great, thank you. I'll come to Will now, please.
Yeah, thank you very much. Yep, and great paper. Plays very much into the last agenda item as well, doesn't it, really, as Ed has touched on. I'm very happy to support the recommendations in the paper. Thank you for that. I've just got one comment and one question. On the recommendation 3D, which is champion and cascade the strategy, I don't have any problem with that at all in terms of the content of the strategy, but I wonder, it's a strategy for 24-29 and it's now 2026, whether it might be helpful to do a July 26 update, because there are also some corrections and updatings that need to be done around, for example, ICB changes and so on. So I think sending somebody a document, a 2024 document saying, please read this and buy into it, might not be as impactful as here's the 2026 update. Not changing the strategy itself, but just making it on the money for today. So that would be my suggestion. And then the other question I had was, we've got a great opportunity going forward, haven't we, with Ipswich Town Football Club and everything around that and Premiership and so on. Is there an opportunity for cascading even further by, apologies if you mentioned it and I missed it, but with working with the football club on further widening the impact of this strategy?
So the football club were stakeholders as part of the working group, so they are fully aware. And interestingly, a former active Suffolk employee has just taken up a role at the foundation as their head of insight. So there's real opportunities there. But absolutely, one of the great things about this is we often find organisations who aren't joined into it, who can be. And I think that's really important to state here. This isn't a closed shop. If someone believes they can add value to this strategy and can support the delivery of it, they are absolutely welcome to come and sit at the table. And Ipswich Town will be very much part of that. Thank you.
Thank you. Come to Sally now, please.
Thank you. I just wonder how realistic it is to imagine doing this sort of thing through transport infrastructure. I agree that we need to make it very easy for people to take exercise, which is taking a walk to the shop, cycling to the shop. In my experience, that is really difficult. In my village, we need road safety measures that it is impossible to get, and I know we're not the only parish like that. Our school actually actively discourages pupils from cycling because they consider it so dangerous. I speak to many people who won't cycle in our village. They consider it dangerous. It's the behaviour of motorists. In my experience, I'm subbing here. My day job is the cabinet member for planning at Baber. In my experience, infrastructure for active travel is a very long-term thing, and that actually getting measures in place to make places good to move around in it's very, very difficult. And we've now been told, the Baber District Council has been told, that there won't be any money for 20-mile-an-hour zones, for example, so that it's going to become increasingly difficult to work with the transport infrastructure system to get anything done. I'm just worried that, the E is going to be just words.
And I hear that, and I've heard it elsewhere as well. I think what we've got to be is brave and aspirational. So whilst I absolutely understand the challenges of that, certainly with existing infrastructure, which is always going to be a significant challenge, we can continue to push hard to try to make changes. But likewise, when we are considering future planning and future communities and what those communities might need, we need to look at the active travel and active environments guidance that Sports England publish and look to integrate that. And I'm very fortunate. I live in Kesgrave, which is held up actually nationally as an exemplar of a community that has been enabled for its population to cycle. And as a parent in Kesgrave, the worries about my children is that they would be knocked off their bike. But actually, there's underpasses, there's cycle lanes, there is a respect for cyclists because there's hundreds of them. So there is a culture requirement, which is why this collaboration is so important. There's also a long-term lens that we need to place on that, and that's hugely important, especially when planning new communities that could be built in 10 years' time. But as I said, it's recognised that there are challenges with existing communities, and anything that we can do to collectively support each other to work within those communities where there might be reticence and pushback, that collective voice will always be stronger than a lone voice.
I'll come to the other Tim now, please.
Other Tim, I like that. Thanks very much, Chair. And thanks very much for the paper, Gareth, and your illustrations, Mark. And I think Ed's kind of stolen the first question I was going to ask, which is about rollout across the county. So it's great there's that collaboration happening already to make that a reality. One of the things that struck me on the paper was this return on investment. For every pound invested, physical activity generates £4.38 worth of savings to health and wellbeing, and that's really fantastic to hear. I think particularly in the context of what we're doing in mid-Suffolk, because we've invested a lot of money in sports and leisure facilities, not just in our main town of Stowmarket, where we've invested a lot of money into outdoor pitches, which are very much needed across the county, but particularly in our towns. So we're expanding some of those outdoor spaces and putting in all year pitches, for example, and increasing the facilities that are available at our leisure centres. And we're also investing 5.2 million in a pavilion, which is attached to providing additional outdoor leisure facilities there. So that's 5.2 million, 2.4 million for our sports and leisure facilities in Stowmarket. And in addition to that, touching on the point that other Tim was making, which is that it's not just about organised sports, I don't think. In terms of this well-being element of it, being able to get outside and go for a walk, even just something like that. So touching on Sally's point, yes, accessing, dedicated sports facilities is a challenge for many people living in rural areas in Suffolk, but actually one of the benefits of living in a rural area in Suffolk is that you're living in a rural area in Suffolk and actually benefiting from the walks that are just near to your house is excellent for getting about and moving, which is one of the pillars of Feel Good Suffolk. Obviously that big piece of work there as well, but also fantastic, which people haven't mentioned here, fantastic for people's mental health as well. So I just wanted to raise those points, but absolutely commend the paper, absolutely commend the work you're doing, and really pleased that there's that collaborative piece to make it a Suffolk-wide piece. Thanks.
Thank you. You come back on that?
No, great to hear of all the great stuff that's going on in Bay Mid Suffolk, and I think you're absolutely right. Mid Suffolk, sorry. You're absolutely right. This is why we use the language physical activity rather than sport, because if you talk to sport about people, it will turn off as many people as it will turn on. And I often use my mother as an example, as that she's 84 years old, she still does Pilates twice a week, but she'd never go to a leisure centre, because her perception of what happens as a leisure centre is that that's people in lycra and they grunt and they moan and people are dancing around, and that's just not her. She'll quite happily go to the village hall next door. And I think this strategy, the beauty of this strategy is recognising that that's important to a lot of the population, is recognising that physical activity is what they need it to be, not what we think it is. And providing those opportunities in their places is really, really valuable. Rural isolation is a significant problem in Suffolk. One of the interventions that Active Suffolk has successfully done over a number of years is the Fit Villages organisation, where we work with those rurally isolated communities. We go into those communities, we chat to them, we understand what facilities they have, and effectively we provide an intervention aligned to what that village feels its needs are in that village location. We provide funding for the first 12 weeks and then we withdraw in order that the community can take ownership of that intervention. And I believe that 90% of those that we have set up are still running under this sort of community ownership. But that's just one thing, and it's recognition of making sure that people are aware of their spaces and can use them and they are accessible. That's going to be important. As I said at the start of this, people who do sport will always do more sport. So if you provide football pitches, that's awesome for people who provide football. What we need to be doing is thinking outside the box and engaging those people who do need support, but aren't necessarily the traditional sports people, physical activity undertakers, in order that they can be supported to improve their activity levels in a way that they enjoy, because if they don't enjoy it, it's not sustainable, and meet their needs. And that can genuinely be anything these days. I think we just need to recognise that. This isn't necessarily about pitches and facilities, although that helps.
Thank you. Come to Karina now, please.
Thank you. Thanks very much. It was really interesting to listen to all of that. My question, Gareth, was really about the Sport England funding that you talked about. I was just wondering what the parameters actually had been around how that had been given, what your timelines were in relation to it, and whether there were things that you wanted or had become obvious that would be good to spend that money on that weren't as part of that grant.
The Sport England funding it's what they call place-based funding. And they used a number of metrics to define places of need within the country. And those places of need were based on previous data with regarding to physical activity levels in those areas. And they also sort of cross-decked that with facilities that were known to be available in those areas. And what that identified in Suffolk was two specific areas initially, that being Ipswich, collectively as a town, and Lakenheath, which was a surprise to ourselves. The reality was that, you know, Lakenheath simply didn't have facilities for its community to use, and therefore that was going to be the chosen area. We as Active Suffolk continue to advocate for a number of other areas that we felt needed more support, and Sport England came round to that, and in a second tranche of funding they have now supported East Suffolk as a place. But again, that's a big place, and what we have done is narrowed that down into 6 specific areas that have been identified as needing more support. In terms of what we're doing in those areas, the first 6 to 12 months was about engagement. It was about asking them what they wanted rather than going in. And we've employed what we call community connectors. So those are people that the initial funding pot allocated to us pays to conduct sort of community engagement, to understand what their community needs are, to engage with those people who are marginalised within those communities as well, to understand what those needs are. And we can bring all that data and insight together in order that we can work collaboratively to provide interventions that work for the community in those spaces. So we aren't sort of, there is no parameters as to what that might be. It needs to be community driven. A lot of this is also driven by youth voice. We've used organisations, trusted organisations in those communities to engage the young people. As Tim said, you know, if we can make young people who are passionate about physical activity, they become adults who are passionate about physical activity, and there's a significant offset there. But listening to them first is the key point, and then building what they need is the kind of the follow-on activity from that. But there are no specific left and right parameters, and Sport England have been very, very flexible in doing that. It's not a case of here's your money, this is what you're spending it on. It's a case of build it, let us know what the communities are telling you, and then we can support the interventions.
Thank you. Come to Simon now, please.
Thank you very much, Chair. Really great paper, absolutely right up my street. As someone who's exercised all their life from childhood to now they're long into their adulthood, it's absolutely ideal. And there's so many things I agree with. Definitely your point, the last point you made, and Tim's point, but children growing up in active families. I grew up in an active family myself. I mean, one of the things that really strikes me is that you know, we've all seen pictures of youngsters, the kind of, you know, young people in the 70s and 80s running around, you know, thin, and then we look at pictures of kids in the 2020s. A very, very different picture. And I think that the impact of ultra-processed food, which everybody knows about, and high sugar, high-fat diets, all those sort of things, has an enormous impact. So fantastic to hear about what you're talking about, Mark, there with families, teaching people how to just, you know, to cook simple meals, nutritious meals, and focus on that. I mean, that's, again, really, really important. I mean, one of the things that strikes me, particularly around exercise, is that it's got to be purposeful. If it's just, well, just do it because when you're 50 you're going to feel better, that's not going to really work for anybody kind of under probably 50. So I think, you know, kind of having things where activity is purposeful, I think the more that we do with that, I think that will encourage more people in. I appreciate that sport in the broadest sense of the term isn't for everybody, but I think there are other things as well. I know that, so I don't know what your links are with, like the Army Cadets. So the Army Cadets have got a scheme which is called 30 by 30, which is an increase of 30% of Army Cadet members by 2030. You know, those kind of, so there's purposeful meaning behind the activity that people do. There will be there's a variety of other things as well. Suffolk has a significant agricultural economy. We've got 41,000 people there or thereabouts employed. Again, you need fit young people to get into that work. The more links I think that we draw in and kind of demonstrate, you know, not just a health pathway, but other sorts of pathways, helps encourage people into more and broader activity. And just the last thing, and I don't know if this is only anecdotal, but is that there's been, you know, conversations about bone density, that the impact of, particularly for young people, and I think the chart you had was like 32% of young people not moving around enough, is that they're seeing more breaks, and particularly in things like, well, unfortunately, the army, you know, where ordinarily people wouldn't. There would be injuries, but not fractures. And I think that's something that good activity will support. And yeah, so so really, you know, very, very supportive of this whole idea. And as I say, really for me, the more I can see about kind of the purposeful activity, the better. I think that will encourage more young people in, and that's the bit that I'm really focused on at the moment. So and particularly around parenting and, you know, kids growing up in inactive households, being inactive themselves. How do we draw them out of that and allow them to get more active in their lives? Appreciate there's not many questions in there, but lots of statements. Thanks.
Councillor, thank you. Really important points you've made there. And as an ex-serviceman myself, I would always support people joining the armed forces. I can hardly walk now because my knees are shot to pieces, but that's physical activity for you. You talked about intergenerational bit there, and that's really important. And one of the big challenges here is that trying to get children to understand the value of physical activity when their parents aren't physically active. And we're now talking, and you'll be aware of this as children and young people's representative, how do we get people prior to being 5 years old to become physically active? And the reality is we can't. But what we can do is reach their parents. And in the slide, we talked about education, and you talked about purposeful. And it's understanding why physical activity is important to them. It's not just something that gets in the way. It's something that's absolutely critical to their long-term health and well-being. And if we can build that education and we can get parents to engage their children in physically active spaces and doing whatever it is that they want to do that keeps them active, that's how it starts. And you talked about being, you know, an active family yourself, and that's where I started, you know. And I'm sure many of us around the room, we had role models who did that. Within these communities that we're talking about, within these people who most need these as physical activities and intervention, life is not as easy. When you're considering whether you can afford to put a roof over your head or feed your children, maybe physical activity seems a long way away. And one of the reasons for that, and we've talked about this significantly as part of the working group, when you talk about physical activity, for a lot of people, they immediately jump to leisure centres, lycra, equipment, you know, special uniforms or joining a club. They don't think of it in the context of just getting out and doing something in the garden, just walking around the block and doing things like that. So that education, I think, is becoming more and more important. Certain communities are set up to be able to do that. And again, I can use Kesgrave as an example. It's perfect for getting out in the evening, having a walk, and you see families doing it all the time. In some of the communities that physical activity is known to be a lot lower in terms of prevalence, those communities simply aren't set up for that. It's kind of, you know, rows of housing, not necessarily, you know, the easiest roads to cross, and therefore people don't necessarily jump to, let's just go out for a walk. So that education piece is really important, and that is the importance of this collaboration. It's all well and good me saying, you know, physical activity is really important to you, but I need the levers within those communities to be able to get that messaging across. And if we can collectively message it through our staff, our work and our communities, then potentially we can shift the dial.
Thank you. Come to Warren, please.
Thank you. Given my day job, you'd expect me to support this item sort of 100% really, and I do. And I do apologise, but I mostly should have declared a bit of a conflict of interest because the provider referenced in the case study is Abercroft. So if I talk from a position of the benefits of the joint commissioning, actually, which I think there's some learning there for the broader sector, that approach has been transformational in terms of how that programme now is sustained in the system. And its ability to have a workforce that's agile to flex the system need. So before that, we might have had a disjointed workforce that might deliver a programme for 10, 12 weeks, then we're chasing a bit of money to sustain that programme. That means we generally lose those employees quite quickly, those instructors and whatever they may be. We now have a permanent workforce that is highly skilled, multi-skilled, with a better quality job, first off. They have a better relationship with the participants within the programme, so it means they can build a relationship, understand those needs, and at the end of that programme, direct them to the most appropriate outcome. So sometimes that's within our facilities. I'll come back to leisure centres in a minute. But other times that might be park run. It might be something that the cadets might be running. It might be something else. And that workforce has that knowledge and that local link there to be able to make those referrals. The other point I will make is some of the money around joint commissioning was new, but most of it was repurposed. So it's not chasing new money. So there's economies of scale in that system to get a better outcome. And that workforce now has the ability to flex towards some of the work in the Healthy Lifestyle Service that the Public Health Team commissioned, some of the Fit Villages work that Gareth's mentioning in terms of in West Suffolk. It has its own programme about Move More Outdoors. We have also got the agility to pick up activity in care home settings, so on and so forth. So we've created a really good model that can be built upon. And I think there's a lot of learning from that about just getting consistency and assurance, whereas in the past, we'd be moving backwards and forwards, we wouldn't get consistency. And perhaps at a future meeting, might share some of the outcomes of that pathway because they are significant, both quantitative and qualitative. So as a provider, we are tasked with dealing with about 1,600 referrals a year in that programme. I think we're dealing with about 3,200 at no extra cost at this stage. So, and we have the goodwill to do that because we've seen goodwill from the system. And we also allow free access to our services to encourage those participants to stay active for a period of time after that. So it gives us the commitment so that we can invest back into those individuals as well and be an active system partner. In my day job and with my pure chief exec, I've got to challenge the perception of a leisure centre. I could not let that go. All right, it's about what happens in a leisure centre that's different. All right. Now, if you go to some of our leisure centres where we are co-located with health system partners, we have seen termed the unusual suspects using our services more often because they access the leisure centre for a different reason. They get exposed to not the lycra, interestingly, because there's a bit of a myth in that. They get exposed to a different set of outcomes, and Valerie's seen this because she's been and evaluated some of our work. All right, and they then participate in their own right. So I think we need to be careful that we don't pigeonhole facilities a little bit. I'm not saying they're for everyone, but at the same time, they are a fundamental part of the system and you shouldn't dismiss and play a big role. Thank you very much, Chair.
If I may, absolutely. Abbeycroft are an exemplar of how leisure centres should operate, and if only we could nationally pivot to the model that Warren runs successfully, I think physical activity would be countrywide in a far better place.
That's great. Thank you, Gareth and Mark. There's nothing further to add. I think we'll move on to the recommendations. It's quite a long list. I'm sure you don't want me to read them all out. They're on page 29 and 30 and paragraph 3 of your agenda pack. And I'd like to ask, is the board content to agree the recommendations of the general affirmation? Yep. Thank you, everyone. And we'll move on to item 8 of the agenda. This is the Joint Strategic Needs Assessment, an update on the delivery and impact for 2025-26, and invites feedback on the future priorities, engagement approaches, and improvements to accessibility and usability. I'll now invite Natasha Bynes, Head of Population Insight, to introduce the report.
Thank you, Chair. Hello, good morning, colleagues. Thank you for your time today. Bit of a long title to get your head around. So to say both looking back and looking forward is the short of that. For colleagues that may not be familiar with the Joint Strategic Needs Assessment, or JSNA for short, it is our underpinning data, research, intelligence and insight piece that feeds into our joint local health and wellbeing strategy. And so There is statutory guidance. We do have to produce one. I think what's really interesting about JSNAs is when you look across the country, across upper-tier local authorities, they'll look different. They'll have very similar themes, they'll have similar data sets that inform it, but actually there's no prescribed way in which they have to be delivered. So we have an opportunity to really tailor our joint strategic needs assessments to our local populations, to our unique assets, so our coastal areas, our rural areas, but also to look at some of those inequalities, those variations in the health and well-being of our residents through that lens. What the JSNA does have to include, though, it has to include a range of data and intelligence and insight products to inform that understanding of our population. It's got to be there to improve our health and well-being of our local communities. It's got to be able to be used to help reduce health inequalities and that unwarranted variation. It's got to be a continuous process. So if you ever hear somebody saying we've finished our JSNA, I would say, no, don't only happen. You need to be looking at lots of areas and lots of different things. Some people may refer to a JSNA as an individual product. In Suffolk, we refer to it as our whole suite of products. So whether it's health needs assessments, whether it's profiles, whether it's voice, all of that encompassed in our JSNA. We've got to engage our local community, whether it's VCFSE colleagues and the amazing work they do, the insights they produce. I was so happy to hear the passion and the use of population health management data, to hear the use of multiple data sources, to see the recommendation in the physical activity strategy. Number one, using data. Yes, brilliant. That data has to make a difference. We have to be going back to that and utilising it within those JSNA products as well. And the role of qualitative evidence, that lived experience, especially from those seldom heard groups, the people that don't show up in that PHM data that was mentioned earlier, that's where that role of voice is so imperative within our JSNA as well. We've got to look at current needs, yes, vitally important, but also looking to the future. What might Suffolk look like in 5, 10, 15, 20 years? How can we best plan for that? How can we bring in that role of prevention, early intervention, and really embed it in our plans, especially those neighbourhood health plans? We must include a pharmaceutical needs assessment, and you'll see a little bit more of that later on. We've got to produce one of those. That is one of those common denominators across all of those upper-tier local authority areas. Everyone will have one of those. Control of market entry, looking at pharmaceutical needs, etc. It must be published and accessible. All of our documentation that we can publish into the public domain is on our website, so on that Healthy Suffolk website as part of the Joint Strategic Needs Assessment. Very small text, but we'll go for it anyway. So what have we done in 25-26? The JSNA, we believe, continues to provide that central evidence base. We continually add to that. We review, we refine, we update, we produce new products where possible. We look at emerging health needs and try and build those into our joint strategic needs assessment products as much as possible. We provide high quality insights on key themes. So we go back to our colleagues, we get that quality assurance. What could we improve? Have we missed something? Is there a population in one of our products that we haven't considered? What do we need to do differently? Was it actively used? Yes, we believe it was actively used, not only by our public health teams, but wider colleagues across the system, whether that's to inform direct commissioning, whether that's to inform research, whether that's used in academia, whether it's used by VCFSE colleagues, whether it's used in grant funding. We want those documents, data and insights used. We noted that user engagement remained high, which is great. We run a survey on a yearly basis, not only to say, what do you want, what's gone well, what do we need to improve. I think one of the things that we would note that is the general website use has declined from the year prior. We do suspect that anecdotally that may have been somewhat impacted by the changes to ICB structures as well as people transition into different roles. That being said, that engagement was still high, about 12,000 website hits directly to that JSNA website. The products were well used, so whether it was our SEND needs assessment, whether it's our JSNA monthly blog, they're all getting utilised, and we're going to monitor that website use and metrics for our products into this year and beyond as well. We believe it helped to strengthen partnership working. So when you can point at a document, a resource and say, okay, how could we do things differently? How could we use that insight and evidence? How can we work closely with our known works colleagues to utilise the voice and insight, things like My Health, Our Future? How can that change the lives of young people in Suffolk? How can we use that data to ensure inequalities are reduced and mitigated wherever possible? So I think I would finally note that, yes, we have everything published in the public domain. We try to produce documents in a variety of formats. So some people really engage with a long report. They love a 200-page document. Other people, not a fan and want a few slides. They want summary on a page. They want infographics. We do try to produce a range of documentation, whether it's a dashboard of figures, a PowerPoint presentation. We recognise that, yes, we have improved accessibility, but there's always more to do, and there's always feedback that we can take on board and build to make our products better. Even smaller text, because I'm really testing eyesight today. I just wanted to showcase the range of products that we produce in 25-26, whether that was the pharmaceutical needs assessment, data updates for the SENS needs assessment, dementia profiles, oral health profile, inequalities profile, healthy weight needs assessments, blue and green space profile, which actually really resonated to me because I read the article in The Guardian this morning about how blue space is being used for therapeutic and surfing, improving not only mental health, etc. How can we use the evidence base to effectively target some of that decision making, some of those future aspirations for improving health and well-being of our residents? Loads of other detailed information on there, including the indices of deprivation. Now, when we talk about our most disadvantaged communities, we quite often use those indices of deprivation as one of those underpinning data sets. So we have targeted profiles for some of our most deprived areas in Suffolk on the website, as well as an overview product on those indices of deprivation, specifically index of multiple deprivation. It's one of our key resources we utilise. What I would also say, if you haven't come across the local insight product, which is my favourite, Data and Maps, that is publicly available through our Joint Strategic Needs Assessment and includes loads of data, but including those deprivation data sets as well. So you can really start looking at local neighbourhoods, local places and thinking, okay, what's the within area variation in that? How can we use our resources most effectively to target our populations most benefiting from intervention? And looking ahead, all of those different blocks are different products that we are planning to produce as part of the 26-27 programme. So whether it is our annual public health report that Stuart produces as his independent report, whether it's keeping that pharmaceutical needs assessment up to date, publishing a sexual health profile, publishing a gambling profile, planning to our carers needs assessment, which we really recognise as an area that we want to update. We know that that is an area of real importance as well. We've got men's and women's health profiles. Some of these have already been published, so I've put a little tick next to them. So publication of our mental health needs assessment, which is informing the Joint Norfolk and Suffolk mental health strategy, amazing. A healthy pregnancy profile, and our constant process, as I say, of maintaining that pharmaceutical needs assessment. So we really do have a raft of products in the pipeline as well. So to summarise, as I say, I really believe that it serves as a central evidence base. I really hope colleagues across this room are utilising it, and if you can see things that you think, actually I want more information, our team are there to support that, so please do come to us. We want you to use it for strategic and operational decision making. We've produced a lot of high quality insights on key themes. We're really working closely with Norfolk colleagues as well, looking at that join up with that ICB areas, including the publication of the integrated needs assessment. So we're really proud of that as a team. Yes, we know that user engagement remains strong, but there is still room to improve, and that's what we spend our days and weeks doing. How can we come to present at your meetings with that key information? How can we help people make sense of that information in meaningful ways, meaningful to their service, to what they do on a day-to-day basis, and use that evidence effectively? And how can we continue to produce those that content in accessible ways, whether it's deep dives, whether it's those infographics, whether it's those high-level overviews, and noting that we need to make the JSNA more accessible, more locally relevant, keep going with that. So I close there, but open up to questions around what further actions can we take to promote and improve the JSNA? Are there opportunities for yourselves to share that, to be more part of the conversation? Please invite us to meetings. We will come along. We will present the data. We will take you on a tour of local insight. And so you can also self-serve in a way that is helpful for you. And if you can see significant gaps, if you think, oh, there's something missing that is, I've got a commissioning decision that is coming up, I need data around this, I need high quality evidence, I need a lit search on it, I need to find out what the latest data tells me, let us know. How can we plumb that into our work plans next year and going forward as well? Thank you.
Great, thank you, Natasha. I'll now open the floor to questions. And if you could raise your hand, I'll take comments and questions in turn. Sorry.
Hi. I love that. I love the whole thing. I spent a very enjoyable trip to Manchester at the weekend reading it. I promise I wasn't driving. I really do. I do love data as well. I've never seen it before. I mean, I'm quite new to this board, so maybe that's why. I think Suffolk care providers will find it really interesting as well, because actually, whether you're doing work for the local authority or you're a private provider, it actually helps you plan the next 10 years as well as an employer of what you might need to be doing and the way we need to shape and change our services. So I'm more than happy to share it with the Suffolk care providers that are part of our association.
Can I come to Stuart next, please?
I was just going to say thank you for Tash for bringing this today. We tend to bring this around every year, and we're quite privileged with the expertise and the resource we have in Suffolk to do this. So I just want to kind of reinforce Tash's point about we want it to be relevant. We want it to be able to help things. We know that with the new ICB forming, it was built on a joint needs assessment between Suffolk and Norfolk, which the team were working on. We recognise that it's about data intelligence, but also looking at Wendy, it's also about voice and how we bring all those things together. And we work very closely with Known Works, often on needs assessments and manual reports. So I think it is honestly an open opportunity for if there are things you want to focus on or there are things important, we will look to try and support that, because ultimately, as we've all the way through this today, is about we're an ecosystem of how we work together. So very much we've got some fantastic resources there, and Tash and the team produce some incredible stuff. And as I said, I think I'd probably point you towards the updated mental health needs assessment, which has come out recently, which will play an important part around commissioning and decision making around that as well.
Great, thank you, Stuart. And I'll come to Tim Passmore now, please.
Tim P, yeah, as opposed to the other one. Yeah, good. No, well, Natasha, I love your passion and enthusiasm. It's really good. And I think it's a very, very important document, and the way it looks forward potentially for several years is just exactly what we need. There's far too much short-termism in what we do in UK PLC, in my view. One of the things there, though, I think, I'm not saying it is missing, a lot of the things that get mentioned, if I put my crime hat on here, well, not my personal one, but if you look at things, for example, like retail crime, shop theft, shoplifting, a lot of that can be related back to substance addiction. Not that that is an excuse. If we then link that game further, very often that can, we're once again back to deprived communities, of course, how we get that out. But using that as a weapon, I suppose, to do that, I've said for a long time, we really, in the public sector, we've only just started on doing this. We should do a hell of a lot more. When you look to public sector procurement, using a sensible use of social value, we could do a lot more in the longer term to help. It's about helping Suffolk PLC, UK PLC, with the balance of value for money and so on. I just wonder, does that get considered at all, or is that something we could meet up and see how that could be incorporated in? Because I think you said at the end there, this document's always been developed, and my knowledge it always is. And I was really, really pleased to see you mention things like mental health, sexual health, and there's very often a very strong link across all of these things. So, yeah, no, I'd welcome the opportunity to do that, because we could refine it more. Because in the end, for me, a lot of it comes down to how the economy is going or not going. And my goodness me, the country needs a bit of help with the economy at the moment, and particularly for young people. But I'll be quiet there, because otherwise I'll never stop. Thank you.
Thank you. I just thought Stuart would like a word on that.
I think one of the steps we've taken forward recently is about some of these integrated data sets. We have for a long while talked about, and we're as guilty as anybody else in public health, we've talked about mental health, we've talked about maybe accidents, young people having accidents, but as you say, a lot of this is an overlapping Venn diagram. And some of the work that's been happening over the last couple of years in kind of the integrated data hubs is particularly around that linked children's data set that we're looking at the moment. One of the scary thoughts is we don't always know which children are missing from which. And then when you start looking at it, actually that's a child that potentially has SEND, may have also things around criminal justice. So the bit we need to be looking at from that kind of, and it comes back to actually the first item today on neighbourhood teams again, about how do we integrate that insight and data together, and also links back to the physical activity discussion about then having integrated pathways around things. Let's stop bouncing somebody off to there and off to there. Sorry, that's not part of our pathway. So for me, it is about the JSNA provides a lot of that strategic framework, and my annual public health report is going to look at data for geographical areas, but also I think we want to talk about integrated data and integrated insights around people, because that's the next step, and we are doing those things, but there's further steps forward about how we can do that and start looking at people at the centre of what we do rather than seeing them as pinging around pathways.
Now a couple of Simon Aalders, please.
Thank you, Chair. Thank you, Natasha. It's a great report. Nice to see you after a million years of not being here, so it's great. And congratulations on your being head of population insight. So my background forever really has been in addiction, homelessness, domestic abuse, crime prevention, community safety, all of these sorts of things. And it's really great to see so many areas of that are really represented within this report. But I'm particularly pleased to see that you're highlighting gambling. I think gambling is, having worked in addiction, I ran a rehab for 5 years, and what we noticed in there were the number of people that we were starting to see with really significant gambling issues. And one of the issues, as I'm sure people understand, around gambling is that it might take a decade or so to ruin a family's economy with alcohol abuse, but it takes literally kind of 24 hours to do it with gambling. And, we've seen some and read and met some really significant, some people have had some really sort of horrendous tales to tell. And particularly for young people, the impact of parental gambling in families and in home finance is just can't be really overstated. And I think that, so it's really encouraging to see that. And I'm glad that it's there, because we can certainly, and we will absolutely, and I know that Children and Young People Services use the JSNA all the time, and we'll continue to do that. And just on a personal note, and for other councillors, when I was elected in May, I was handed a folder, and in that folder was all the detail that I needed around the constituency in terms of population demographics, in terms of all of the kind of deprivation and all the other things that you've listed in your reports. So, fundamentally important for any councillor, any elected representative to fully appraise themselves of that information, because it just highlights the constituencies that you have in a much better way, I think in a much more informed way than maybe we would have anticipated. So thank you very much.
So we come to Warren, please.
Thank you, Chair. Just an observation, I suppose, linking back to the first item around neighbourhood health. It feels like would be more, I don't know whether there's an opportunity that as neighbourhood health items come forward at the sort of JSNA at a place-based level is sort of presented first, if you see what I mean, to identify the issues, and then it brings it, sorry, it sounds very condescending, it brings it to life, if you see what I mean, in terms of what the art of the possible might be. So then the neighbourhood health plan that's moving forward is a direct link to it. Does that make sense? Sorry.
Thank you. I would love that to happen. I would love us to be able to have a bit of a data pack, data overview about areas, and then link that into future board papers. Definitely something, Richard, we can take offline with programme office planning. I think for me, the thing I'm most passionate about is that the data leads to decisions. So I don't want it floating around in an ether. I want it actively targeted. So any ways that we can absolutely improve that, 100% behind it.
Thank you.
Yeah, I just wanted to say, Natasha, we are using this in children's services. We have all these national reforms dropping at the moment, and we are using them for our service design work, so, and dovetailing in with demand analysis as well. So thank you for the work that you've done on that.
That's great, thank you. If there's nothing further to add, we'll move on to the recommendations. The recommendations for the board are shown on page 77, paragraph 3 of your agenda pack. Would you like me to read them out? Well, it's to note the progress, developments and impact of the JSNA over 2025-26 as outlined in the annual review, to promote the use of JSNA products across board member organisations, encouraging its use in strategic planning, commissioning and service design. And item C, provide feedback on proposed JSNA deliverables for 26-27 and to contribute to shaping the future of the JSNA work plan. Is the board content to agree the recommendations by general affirmation? Thank you everyone. And we'll move on to item 9 of the agenda. Agenda item 9 provides the board with an opportunity to consider the Get Suffolk Working and Work and Health Plans. I now invite Michael Gray, Head of Skills for Suffolk County Council, and Helen Bowles, Head of Work and Health, NHS Norfolk and Suffolk ICB, to introduce the report, please.
Thank you, Chair, and thank you all for the opportunity to bring this item to the board today. I think it follows on very well, actually, from many of the items that we've already heard from. Really continues that strong theme of coordination, integration, and enhancing our services and interventions across various organisations, I think, very, very well. So both Helen and I are here today representing the Get Suffolk Working Delivery Group to provide an update on 2 very closely aligned plans, the Get Suffolk Working Plan and the Work and Health Plan, otherwise known as Fit for Work, Fit for Life. These are not fully funded new programmes of activity. For any of you that remember Get Suffolk Working coming to the board at some point last year, I was very keen to emphasise that point. These are actually better to think of them as strategic umbrellas that bring together relevant skills, employment and health activity that's in development or in delivery, primarily across the county councils, the Suffolk County Council, the Integrated Care Board and DWP, looking after our jobs centres in the area, but also obviously working closely with colleges, with our employer representative bodies, primarily the Chambers of Commerce, employers, the voluntary sector, other local authorities, housing associations and the justice system. There's probably a category that I've forgotten there, so if there is, my apologies. All with the aim to help create more coordination across work, health and skills, so we can strengthen our understanding of both the issues and what is already being done to address those issues. Help inform future policy development, make best use of our resources across our organisations, and jointly identify shared priorities, and where it is possible, with the resources that we have, to then take further action, whether that be more research, engagement with a particular priority group, or co-development of further activity. So reason for bringing to the Health and Wellbeing Board today, although Get Suffolk Working has a slightly wider remit than simply, obviously, health and wellbeing, there is clearly a strong overlap with the priorities of this board and hopefully the objectives of many of the organisations represented in the chamber today. Health and wellbeing clearly has a very integral role in enabling the progression to and within work, as I think has been referenced in several of the items earlier. Therefore, although Get Suffolk Working, it does have its own decision-making arrangements, so there is a partnership board which the 3 signatory organisations sit on, and there is a Get Suffolk Working delivery group which brings together officers from across the three main organisations, plus our local authorities, and we are looking to expand that group as well, which I'll come on to later. But we want to bring this to Health and Wellbeing Board as an opportunity for you all to note progress, hopefully confirm that you remain supportive of the ambitions and objectives within the plans, and provide any strategic steer you wish to provide, including, hopefully, any means by which the board could further support those ambitions. So if we start with the Get Suffolk Working Plan itself, And I appreciate, again, this is a bit of a recap for those of you that heard me speak last year, but appreciating that there are a few new members in the chamber. When we come again with this item in future meetings, I probably won't look to go through this detail, but for the purposes of today, Get Suffolk Working, approved and published in November 2025, signed off by the County Council, as well as Norfolk and Suffolk DWP and the Integrated Care Boards, following a range of consultation with wider partners and some groups of participants and public. It was Suffolk's response to the Get Britain Working white paper. All local areas were asked by government to produce local plans, setting out strategies and actions to support the national ambition to reduce economic inactivity and raise the country's employment rate to 80%. We were required to set some related local ambitions that an alignment and enhancement of our work across our organisations would help then meet that national target. As mentioned, in absence of any additional resource or funding, this was about bringing together and looking to enhance what we were already doing to help achieve these ambitions. These ambitions being the 5 boxes you have on that slide, matching the national ambition for an employment rate of 80% alongside an economic activity rate of 80%. And although we fare comparatively well at a county level on this to many other areas of the country, there still are many people, obviously, with complex barriers for whom the path to employment is not overly straightforward. Health conditions, disabilities, caring responsibilities, low confidence and rurality, just some of the barriers that some of these individuals may be experiencing. And alongside that as well, we know, certainly in the skills team, that employers often do still struggle to find the people, the workforce that they need to progress. So really important, obviously, for us to do everything we can to ensure that everyone in Suffolk who is able to can work and has the opportunity to do so. In terms of halting the rising trend of health-related economic inactivity, at the time of the publication of the plan, we were seeing an increasing amount of inactivity that was down to health. In particular, mental health was a big driver of this, with anxiety and depression, a combination of those two things, the most prevalent condition. In terms of reducing the disability employment gap for people aged 18 to 66, although this was fairly comparable to the rest of the country at the time, we have a rising rate of disability within the county, so clearly really important to do all we can to close this gap to make sure that we widen those inclusive recruitment pipelines for our local employers. Increasing the employment and economic activity rate for women, whilst also maintaining a focus on the reducing rate for men. We had a larger gap than the national average between the economic activity rate for men and the economic activity rate for women. But unfortunately, although the gap was closing, it wasn't closing in a way that we would ideally like, i.e. the economic activity rate for men was falling and the economic activity rate for females was only just creeping up. So it was closing, but not necessarily in the way that we would optimally like. Reducing the proportion of young people 18 to 24 not in education, employment and training. Lots of people have picked up on this today. Dare I say, we all now are much more familiar with the name Alan Milburn over the past few weeks. And that report really does sort of hammer this home, that across the country we now have over 1 million young people aged 16 to 24 who are NEET. And Suffolk is unfortunately no real different. We are seeing rising levels of those that are NEET and unknown. So what progress has been made since the publication of the plan? For those of you that have perhaps read the full, I think you referenced 200-page plans earlier, Natasha, the 200-page plan of the Get Suffolk Working Plan, you may note that there are an awful lot of proposed actions that were identified as a result of the consultation work we undertook last year with a whole range of different stakeholders. Obviously, we're unable to do everything all at once, but I hope you'd agree that some good progress has been made to date that the Get Suffolk Working Delivery Group and the Partnership Board has overseen. So in terms of those headline ambitions that I mentioned, we've seen the economic activity rate now stand at 81.9%, moving from 80.5%, so a positive trend there. Employment rate has also moved up positively by a couple of percentage points. Health-related inactivity is now slightly lower than it was previously at 5.3% compared to 5.8%. And the economic activity rate for women has increased quite significantly from 74.8% when we wrote the plan to 81% now. Obviously, as with any data, there is a bit of a lag in data. So that is, just for clarity, referencing January to December 25 statistics at the moment. Our next plan will obviously be updated, or our next report will obviously update those figures. Our key programmes of activity, so we identified several ongoing programmes of activity within the plan that we felt were really central to achieving our ambitions. Those included things like the Thrive Skills and Employment Service for young people, the work that we've been doing around supported internships, our Apprenticeship Suffolk service, which supports people to access apprenticeship opportunities, and our Skills Bootcamp programme and adult learning services, which obviously help to make sure that people have the skills, capability, confidence to move into employment, as well as our Good Health at Work project, trying to make sure that workplaces were as good as they could be to help with retention and recruitment. All of those key programmes have met or are on track to meet the vast majority of their targets, so that is all in a good place. Funding identified and secured to keep key activity running. A lot of this type of activity is funded through external funding streams. In the past, through a lot of European structural funds, and more recently through the UK Share Prosperity Fund. So as those have fallen away, we've had to find new funding opportunities, and I'd like to say that Get Suffolk Working as a way of working has been really key to us being able to identify those funding streams to continue some of those key projects. The launch of Connect to Work, which focuses on supporting those residents who have some key complex barriers to work. That is up to £9.5 million worth of activity we're receiving from DWP to support more than 2,700 Suffolk residents over the next 5 years. Public and employer-focused communications campaigns. So work has been undertaken to promote those benefits to employers of focusing on healthy workplaces, staff retention and inclusive recruitment. And something that I really want to focus on today as well, not only the continuation of Apprenticeship Suffolk through funding that has been identified, but the actual enhancement of what we do through that service. So whilst we were offering up to March this year a service that focused on providing support to get people into apprenticeships, we've now extended that to be about also the support that employers need to create those opportunities as well. So there is increased guidance for employers to include apprenticeships in their workforce development plans, to navigate through the system, to create those opportunities, and even to fund them through trying to improve the rate at which we see levy transfer happen in the county. And for those of you that aren't aware of the apprenticeship system, very briefly, obviously there are levy payers who are of a certain size who have to pay into a apprenticeship levy. If they don't use that for their own purposes in terms of upskilling their own staff, then there is the opportunity for them to use some of their unspent levy on other organisations. We want to facilitate the transfer of that levy from our bigger employers to our smaller employers to hopefully create even more apprenticeships in the area. We have a target of hopefully facilitating at least £1 million of that levy over the next year. And I'm pleased to say SCC, Suffolk County Council, has pledged already some of our unspent levy, and it would be great to see as many organisations that are able to do so in Suffolk. In terms of our key, sorry, I've moved on a bit quick there for you, Helen. I've got one last point I want to make, hang on. In terms of our key priorities moving forward into the next phase of delivery, we're going to be focusing on the development of an approach to better monitor key causes and drivers of economic inactivity, obviously building off the work that we already have, the data that we already have, the joint skills needs assessment, for joint strategic needs assessment even, that we have, that Natasha's talked about. Exploring alternative funding options for the continuation of some impactful services, and expanding the delivery group, as I mentioned earlier. What we'd like to do is make sure that we have some voluntary community sector representation, and some justice system representation on there as well. We'll also be heavily focusing in on the young people angle, so looking at what opportunities there are to maximise the impact of all aspects of the youth guarantee, things like the jobs guarantee, youth hubs, prioritisation of the use of incentives that are now out there for employers. But now I think I can move on to Helen. That's okay.
Thanks, Michael. So Fit for Work, Fit for Life was the ICB Work and Health Strategic Plan, which was written at the same time as Get Suffolk Working, so we aligned the two plans quite tightly, and but obviously the Fit for Work, Fit for Life was much more detailed about the health barriers, which are the biggest reason for people who are economically inactive across the country. The plan was co-designed with system partners, people with lived experience, and we used our population health management data as well as Natasha's JSNA to be able to inform how we effectively move forward for our communities, with the aim of addressing health inequalities, increasing our life expectancy and reducing the differences between our community with their average life expectancy, and contributing to the economic development within our system. It uses a whole life course commissioning approach. So what you were talking about earlier, Tim, around we need to start from day one of life in terms of how we can support people, children and young people into work, and then throughout their whole working age. So within that, it's got 5 priorities that we focus on around our population health, so that primary prevention, linking in with the schemes that Mark and both Marks were talking about earlier, in terms of looking at what is within our community and supporting our communities effectively, focusing on children and young people as early as possible within their life, supporting those people who aren't actively involved in employment at this point, but also supporting people who are in employment with health needs to be able to remain well and retained within their workplace. And obviously to support our employers as well, so that they are as well informed as possible to help their employees with health needs. We wanted to move beyond the employment support alone and look at that prevention. So one of the shifts within the 10-year plan of the NHS is moving from intervention to prevention. And this very much looks at that in terms of how can we prevent. If we can't prevent, how can we get involved as early as possible in someone's situation? But also looking at our society, how can we make our society more inclusive and accessible for people with health needs, and working very tightly with local authority colleagues and DWP. So between writing the 2 plans, it has really formulated a strong strategic relationship with the DWP, and we work really tightly together now, much more than we ever have. So far, within that plan, so again, it was published in November, we've made quite significant movement in terms of the actions. About a third have been completed already. The first few that I just wanted to sort of cover off as examples of what we've been doing. With local authority education colleagues, we've looked at earlier identification of children that may have the risk factors that we can see often in our young people that don't manage to access employment, education and training, and we've done a bit of sort of research into our local young people and seen that actually it is statistically robust to look at children in year 5 and look at risk factors that they have then as a good indicator of whether they are likely to be become NEET at 16. So we've developed a toolkit and worked with some local schools to develop that, so that we can then be supporting the teachers to identify those risk factors with the children, help them to ensure that the children are accessing the right services, but also link our families into the offers that are available within the neighbourhood, such as the scheme that Mark was talking around healthy meals and physical activity, and are very much working tightly with Active Suffolk on this aim as well. So that's sort of one area that we're looking at sort of earlier on in a child's life. Within the toolkit, it then helps secondary schools to monitor those young people and to continue to review their risks to see whether further support is required. So that's obviously going to take us a little while to see the outcomes of that. But what we have been finding in the pilot schools that use the tool were that there were a number of children that weren't perhaps high up on the radar within the schools because they had a number of smaller risk factors that they weren't always aware of, or it wasn't until you put the number of risk factors together that you could see that that child actually was having quite a complex situation at home that we could be intervening with. As Michael said, we've done a public campaign about work is good for your health, and explained how that is a wider determinant of health, and that's been aimed at the public as well as employers, making them aware of what support is available to them to support their employees, which seamlessly moves on to some support material that we've developed. So we've set up a website that then signposts people off to all system partners' services and resources that they have. But we've also developed some short educational films around mental health conditions, musculoskeletal conditions, the main conditions that people find are a barrier to work. We've developed a reasonable adjustment guide to give employers ideas of what they could be putting in place, often for no money or very little money investment required, but is around just changing slightly, but is benefiting their whole workplace, not just the individual that they may be seeking help for, as well as putting in an accessible, inclusive workplace checklist to again help employers to just reflect on their workplace. We've recently launched, in combination with many system partners, the East Coast Employment Partnership, so particularly looking at Great Yarmouth, Lowestoft and Ipswich. So our coastal communities, as many of you will be aware, have much heightened health inequalities, even compared to our rural communities. And so we were looking at how we can work together with those 3 towns and surrounding areas to develop 500 opportunities for young people to move nearer to work. So it might be work experience, it may be work tasters, helping with CV writing, to actually developing, helping them to get into access employment. So we're working with local employers and statutory organisations to try and make that happen in the next year. And then the other scheme we are working on is called the Workwell scheme, which has been funded by the joint DWP and Department of Health and Social Care team. We have £6 million over 3 years for Norfolk and Suffolk. And this is about early prevention for people who are currently in work, who are struggling to stay there, or who may be having absence from work, or who have fallen out of work within the last 6 months. So sort of more sort of live issues that they are struggling with. We issue 240,000 fit notes or sick notes in the old phrase across Norfolk and Suffolk every year. So we know there are a huge proportion of people who need this support. And about half of those have more than one fit note within that period of time. And when we look at some people who have 3 or more, 70% of them have more than one long-term condition. So although we're living longer, we are developing long-term conditions earlier. And so it's about supporting working age people as much as possible. There's a multidisciplinary team that will help them with their health needs, do some brief interventions, and work in health coaches that will then link and support that person as to what matters to them, whether it be their housing difficulties as well as their work-related issues, to try and look at the whole person, their whole family unit, to see what we can help them to access within the system to help them with their needs, which are often maybe the root causes to maybe mental health or musculoskeletal conditions in the first place. So this will go live in November, early November. And so obviously next time we come along, we can be explaining where we are. We're currently in a procurement, so a little bit limited what we can talk about in terms of that, but are looking to have a collaborative approach across system partners in delivering that within Norfolk and Suffolk. It's also seen as a hub for our health, employment and skills ecosystem. So again, there will be warm handovers for people that would benefit from the skills and development section with services that are available, as well as supported employment opportunities for them. And it will have a no wrong door philosophy. So that's quite a significant service that should be coming live by the end of the calendar year. Our next phase in terms of moving forward with Fit for Life, Fit for Work is obviously the delivery of work well and seeing the impact that that will have and measuring the outcomes for our participants. We're also designing employer-focused events to help them understand main conditions. We've hiring the Autism Reality Bus and taking that out to Gateway 14 to educate the employers there about understanding and appreciating what it might be like to be neurodiverse within a workplace, and then helping them to understand the reasonable adjustments that could be given there. Supported community days for people who are not in work, and again bringing them to a central location where we can help them with their health needs as well as their wider determinants of health. We will have organisations that will support helping people into volunteering, so maybe not necessarily moving them into work, but helping them with their confidence and self-esteem to help them move that step forward. We'll be rolling out the NEAT risk assessment tool in the next academic year, and we've got some multi-academy trusts who've signed up to really work with us in partnership to understand the learning from that. So in terms of the next step for us all, so we just wanted to summarise really that we've worked as close as we can to align our plans and to be able to have informed conversations with our employers, that if one of Michael's team can go into an employer, they can also talk about the health offer that's available and what's on offer from DWP and vice versa. We've got that greater understanding of each other's agendas and what services are available so that we can support people and wrap around them. In terms of our movement with both plans, we've made positive movements to date, a lot more to go, and we do have some challenges around that. So as Michael said, we are using a lot of short-term funding pots to try things. There is an evidence base around investment in this area does have a return on investment, but again, we need to understand that with a local lens. And so another challenge we had with both plans was having one concrete data set, because we need to triangulate many data sets to come to a conclusion of where we sit. We've now got to that position, and so we then need to be able to measure that impact. But there are still a couple of areas that we are lacking data. So for people with learning disabilities and for our young people not in education and training up to 24. So Tasha, we might be knocking on your door to help us with that. But also, yeah, those are our main risks. I think the strengths that we have as working as a unified triumvirate help us move much forward with that. And as someone was saying earlier, a joint voice is much louder than single, and I feel that we have made progress as a result of that. So we just wanted you to receive our update today, but are proposing that perhaps we come back in winter 26-27 when we can be looking at that data and the outcomes in a bit more detail than we've been able to go through today. Thank you.
I think just to add one last point, which that's okay, that I realise I think it's an important point to make in terms of risks. Whilst there are three main organisations that obviously signed off the plan in terms of the ICB, DWP and Suffolk County Council, absolutely recognise that a lot of what we do across the county relies on lots and lots of other stakeholder organisations. One of the risks we do recognise at the moment is the funding element that you mentioned, Helen, but then the onward impact that has on the voluntary sector and other really key parts of the whole ecosystem that supports this agenda. So that's another key risk. We've seen a couple of fairly notable charitable organisations fall to the wayside fairly recently. I think that's another thing that we are very, very aware of. Thank you.
Thank you both. I'll now open up the floor to the board. Please raise your hand. But we'll start with Ed, please.
Yeah, thank you. Excellent work. I think you're both a role model for the integrated working we want to see in Suffolk, so thank you very much. I was just reflecting back on the other items, so, and I might be looking at the world in a simplistic way, but how could this dock into the neighbourhood teams, to the physical activity, so you're having kind of a single view of the client base, as it were?
Yeah, so What we're trying to do by this work is to integrate in rather than having a sparkly something over here that's quite removed. And so we have been looking at how we can incrementally look at those opportunities, particularly because we don't have additional funding for all of this element. So there has been a role around educating colleagues about the impact of work on health and health on work, and looking at where we can embed that within the neighbourhood plans going forward. Looking at how we can support whole family units as earlier as possible, linking in with our CYP colleagues in terms of Family First. We've facilitated the mental health support teams from schools to be part of those teams and co-locate. So I would say it's seeing opportunities and then using that as a way of increasing people's awareness of the agenda, and the database that we're now getting around particularly our young people, and sharing that data across health, social care and education is really key for us in terms of that longer term prevention role that we need to do. I don't know if you want to add, Michael.
I think all I was going to add as well is I'm conscious that there is an awful lot of activity going on. There's also a lot of attempts to coordinate that activity that go on as well. And what we wouldn't want to do is duplicate in any way the efforts that we've heard about today that are happening at different levels to coordinate different Venn diagrams. I think Stuart mentioned earlier, but there's almost different Venn diagrams of the coordination that's trying to happen. So we're very, very aware of that. Our intention as a Get Suffolk Working delivery group is always to try to understand best what's happening first before we then look to actually take any action that is included in the Get Suffolk Working plan. So the delivery group hopefully has enough representation from across the relevant organisations to help assess that in terms of here's a priority, what's already going on, what further action do we need to take.
And I think as well, just linking back to the frailty discussion, this cohort of working age people with comorbidities are our future frailty cohort, and so it's very much around how can we support people at this earlier stage so that otherwise they're going to be the future 1%, 5% that we're still going to look at in the future. So this is our opportunity to really improve health and well-being in a working age population, to reduce that frailty and level of support that's currently required within our system. So it's just trying to embed that within our plans and widen our thinking to working age people who are increasingly presenting with quite complex health needs.
Yeah, go Tim Passmore, please.
Thanks again, Paul. I mean, this is a very important piece of work. There's absolutely no doubt about it. And I'll tell you a very brief story. We went up to the Witton Estate in Lowestoft a couple of years ago, and that had quite an effect on me because, and this was to see young people on the Fit and Fed programme, and it is a very deprived area. And I think somewhere within this, we need to try and engender a better feeling of optimism, because the lack of ambition for them, and I'm not blaming these individuals at all, it's a difficult area, and as usual, we come back to the same old story, deprived areas. Where is the hope? Where's the aspiration? And if you take the premise that everybody is good at something, which I absolutely believe in, we need to do much more on that. And I was really pleased to hear you talk about volunteering, because if that makes a youngster in particular more employable, it must be devastating for those that have tried for many applications and got nowhere. We have to do something. I'll use my old friend procurement again. What are we collectively doing about it? Plenty of talk and yap. Where's the action? That's not good enough. So that's something we can do. And I just wanted to share with you, we're just starting a programme very, very soon. We put some money aside in the budget for a programme, look at the criminal justice system. Those leaving the criminal justice system, and it isn't just prisoners, because not everybody has a sanction in prison, but we're just about to start, and I hope with East Suffolk Council, if we can get on with it, a programme called Prisoners Builds Homes. We're putting some money in, I think the council will, and I hope that's going to get there, because that will give people who've had their sanction a chance to get going. A lot of them will be young blokes, all right? So that can be done. And I just wonder perhaps we ought to get together. And the final point that I really want to get, how well are we coordinating with all these different programmes? And you know, I'll hold my hand up as well, and I'm not blaming anyone, so that we know who's doing what where and how we can actually do that. And you know, when you come to look at the planning system, what are we actually doing within that? And I don't know whether we can do it, about local supply chains for all these, far too many, in my view, houses being plastered all over Suffolk. I know we've got to do our share, don't get me wrong, but that will help some of them as well. You look at the military, they're really, really short of people. And the final point is, I was talking to some civil engineers yesterday, because some of the big projects, they are really, really short of those, not just for the manual work, but for project management and supervisory roles. Most of them, if you look at Sizewell C, whether you like it or not, most of them aren't coming from Suffolk or Norfolk. They're coming from miles away. If you look at the Thickthorn roundabout up in Norwich, to Skanska or whoever the people are doing it, most of their supervisors are coming from all over the country. So longer term, we need to be looking at what we can do, because this will all relate to mental health and general well-being. So I'll shut up now, Chairman.
Have you got any comments on that?
Yeah, so aspiration is definitely a theme, Tim, and just talking to University of Suffolk a couple of days ago around, you know, young people are having difficulty accessing work experience in year 10, and so we were talking about, you know, how can we help young people to see that there are apprenticeship roles into the NHS. You don't have to, you know, you can aspire to go to university. It doesn't mean that you have to go down the academic route. Could we use the facilities at the university and get the young people in through their work experience to be doing some project work there, to teach their peers around how to access different careers from different ways rather than always being focused on the academic route. Another piece of work we're doing, which I didn't mention earlier, in Felixstowe and Great Yarmouth, is looking at intergenerational worklessness, where multiple members of the family have struggled to do that, and working with not only the young person but their parents as well, and bringing them in, talking about how to support the young people's mental health or digital safety, etc., but also then, whilst we're having those conversations, looking at how we can support them better as a system, again help them move nearer to work, and reinforcing those aspirations are possible for our young people. There are a lot of opportunities within Suffolk, and we need to be helping those young people to see the art of the possible. So both County Council and Health have a really robust social value template, which completely covers what you're saying, and certainly within Workwell there's a huge big social value weighting in that. But a colleague within the ICB also sits within that housing space to be checking in and making sure that we do look at how do we support people with health needs within the workplace as well. So there are lots of things going on, as you say, and it is difficult to keep a track on it. And we did a huge mapping exercise at the beginning of both plans to see what was going on in the system, but it's ever evolving. And I think that is a challenge in itself in terms of trying to get to different forums. So I didn't make it to the reducing reoffending group this week, but you know, we're trying to sort of get as wide across as possible, and I think that's sort of one of our asks of the Health and Wellbeing Board, really, is to help facilitate any areas that we may not be aware of, to sort of help us link in as much as possible so that we can get a wider spread and integrate things, so that we're not duplicating and we're using our resources effectively.
Thank you. Come to Stuart now.
Thanks both. A statement and ask and a question. So, I mean, first of all, I sit on one of the groups around this, and we had the first meeting recently. I mean, I just do want to say it's been great to see how we've come together around this. I know, to be honest, there was a bit of a kind of, okay, so we're going to have to write this replan. There's no resource coming with it, but actually it has shown that, again, my favourite overlapping Venn diagrams, there was a lot going on, and actually if we can make it better for residents by trying to be coordinated, that's really important. So thank you for coming with the intentions around that. I think it's just to remind people of an ask. There are some of this is complex, but actually some of this is simple. So one of the asks in there is about that apprenticeship levy. A number of you could walk out of this organisation today and bring that back to your office, as if in a political organisation, say, how and can we help contribute towards that? So as Michael said, there's been an initial fund with an idea of doing that, but there's no reason why for those of us who do have it, go back, because most of the time we do underpay it and there are other organisations who can make use of it. So I think that is a really tangible thing. And I think I was just thinking about the wiring piece, and obviously one of the areas that funding has come down separately in the past around this is around the individual placement support. And I'm thinking about both from public health, we commission it for substance misuse. I think ICB colleagues, you commission it for other. How are we trying to map some of them in? Because there will be an overlapping issues around, going back to Tim's point about substance misuse, and I'm just trying to think about how we point people down all these different avenues and how we can try and bring them together into kind of an integrated pathway.
Yep, so I am working with colleagues that commission the IPS services, particularly around developing the Workwell model, so that again, it could be a central point for employment support. So if someone knows they have someone with a health need, it could come into Workwell and we will make sure that it goes to the right organisation. The same with Connect to Work if it's someone that's further away from work. So we're trying to integrate that as much as possible. Anything we're putting into practices about Workwell, we're including the whole offer so that people are aware of the IPS schemes as well as the talking therapies, employment advisors. So we're trying to use any opportunity we have to sort of cover the whole breadth on what's on offer so that we can get those messages out there, but equally all understand each other's services so that we can make sure that the person gets to the right service for their needs, really.
Call on Simon now, please.
Thank you, Chair. Yeah, again, fantastic report. I have kind of skim-read a lot of it. I got to page 114. But so one of the kind of a couple of things really. I mean, I think that Tim's absolutely right, and I know it's been shared as well. You know, ambition is a fundamental part of a young person's life, and if we, and I've spoken to quite a lot of young people over the course of my life, and remembering what it was like being a teenager and having no fear about your future was a kind of fundamental part of growing up in the 80s. And yeah, I'm talking to young people now who are genuinely fearful about their futures, and that to me that horrifies me, because you should never be thinking about that. You should just be thinking about, I want to go and do that, or I'm going to try this, and I'm going to go over there and do, and just experimenting and seeing how where life takes you. So anything that kind of improves ambition. I spent some time recently with the Eastern Education Group, and a young man there called Ryan Frost, who was dropped out of school, was a NEET. And he now works in there inspiring other young people, and that was a really fantastic kind of example, really, of the work that I know that the Eastern Education Group do a wide variety of different things, but again, a really kind of fundamental part of helping young people break those cycles, really, and get into employment. When I was running the drug action team, we did a very short, sheltered kind of employment scheme, and I think which was a good thing. We put some people. We had some housing stock that wasn't very good, so they then worked with the housing provider to repair these things, and they then became the tenants. The problems that we then faced were there was no work after that, and that was a real challenge. I took that work on a bit further on when I ran rehab in Ipswich, and I was working with the East of England Co-op, and we were looking at a sheltered employment scheme where people coming out of addiction, we were doing the therapy, if you like, keeping them kind of clean and sober, and the East of England Co-op would be doing the employment, and that was a really good sort of synergy. Now, unfortunately, COVID came along and torpedoed all of that, but I think as a principle, there's something in there, I think, and certainly something for maybe us as organisations to consider, that you don't just hand somebody over to an employer. You actually have support alongside them to keep that going. I'm looking through economically inactive, and I'd like a little bit more detail around that, because I know retired people come into economically inactive, and I think that skews it a lot. And I mean, I'm looking at the chart on page 114, and according to this, all the economically inactive people in Baber and Mid-Suffolk don't want to work. Are they all retired, or is it something else? It's kind of, You know, so it gets a bit, and for me as well, I get the percentages, but if there were some actual numbers there, I think that would be really helpful. And there are many different diagrams in there, but some actual numbers so it's also easier to chart some of the progress, I think, that we can see. And I appreciate numbers are very, you've got to have a plus and minus against every number. I understand that. But I think just something like that also helps, because 17.4% and 17.3%, okay, but what does that actually mean in that population group that's being represented, or whatever. So, but overall, obviously, a phenomenal piece of work.
Great, thank you, members. If there's nothing else, sorry, Michael, did you want to?
I was just going to come back very briefly, if I may, and reflect on those couple of points. So just to confirm in terms of the support that's needed for an individual once they go into work, the Connect to Work model that we mentioned earlier on is exactly that. It's sort of about place maintaining and supporting. So both the employee, who has whatever the complex barrier that they may have, and the employer receive some support from that Connect to Work service. So it's not universal across everything that we do, but certainly that particular service is doing exactly that, because I completely agree that that's really important. And in terms of the data, congratulations for getting that far through the document. Thank you that somebody's got beyond those pages. I imagine you're into the annexes at that point, beyond page 100. So recognise that certainly at a district level, a lot of that data isn't overly robust. It's based on population survey, so when you come down to talking about numbers, we can do it, but again, it's almost needs to come with a big caveat that this is representative and indicative rather than actually fully the case. Yep.
All right, thank you. So if there's nothing further to add, we'll move to the recommendations. The recommendation for the agreement by the board is shown on page 84, paragraph 6 of your agenda packs. Is the board content to agree the recommendations by general affirmation? Lovely, thank you everyone. Now, agenda item 10 is the information bulletin, which can be found at pages 93 to 94 of the agenda pack. The information bulletin is not an item for discussion, but simply for the board's information and for noting. Any matters which arise from the bulletin requiring further consideration can be raised under the forward work programme. So we'll therefore move on to agenda item 11, which is the forward work programme, which is set out on page 95 of your agenda pack. And does anyone have any further comments or questions on the proposed forward work programme? I take that as a no. So thank you very much. So everyone is aboard content to agree the forward work programme by general affirmation? That is a yes, thank you. Right, well, thank you everyone. That concludes the business for today's meeting. Thank you for making me feel so welcome, and I've enjoyed your presentations. There have been some great presentations there, thank you. But please, can you ensure you take all your belongings, your paperwork and all your rubbish with you? And I now officially close this meeting. Thank you.